Yes.
Thank you. Professor.
We will not be covering any particular body part cancer in this chapter. The individual system chapters are all over the textbook, meaning for each body system, for instance, kidney cancer will be in a kidney chapter. Okay, so this will cover, because it wouldn't really be it will make a difference, because regardless of the location of the cancer, treatment will be the same. And because the modern modalities for treating cancer, namely immunotherapy, monoclonal antibody treatments, remain very expensive and out of reach of the common US citizen, we will still cover only the three traditional means of treating cancer, namely surgery, chemotherapy, and radiation. Okay, so only those three. And for purposes of chapter 12, we will cover the three main side effects of chemotherapy, which we will cover today. So let's start with the statistics. So we will go to cancer.org. We will use this as the basis for our primary and secondary prevention. More in particular will be secondary prevention. Secondary prevention involves screening. Okay, I'll come back to this later. I'll show you how to get to the website. The textbook is more or less up to date, but the American Cancer Society is the website used by the NCLEX. So we will have to use the current information. I'll share something with you. In 2016, it was spring, so I was discussing the chapter. And then when we got to the secondary prevention section, so today I showed them on the website. These were the recommendations. Literally 2 weeks later, a few days before the exam, the website changed the recommendation. So the age changed, the frequency changed. So that's how the website, the cancer, American Cancer Society recommendations can change. Okay, of course, I don't anticipate that happening anytime soon, but we never know. What comes to mind when you hear the word cancer? Death, right? Okay, so we associate it with death. What else?
Hair loss.
Death, hair loss, pain. Okay. All right. So when the patient hears the diagnosis, is the patient's mind really on what the doctor is saying?
No.
So are you a mom, Ms. Chanava?
No.
No? Who are mommies here? Okay, Miss Green. When you're diagnosed, when you hear a diagnosis of cancer, what will be the first thing on your mind? Oh, Miss Chioma, sorry.
That is coming soon.
Okay, so will you be thinking about yourself or your children and your husband?
About who take care of my kids.
Okay, so will whatever the doctor is saying be will you be conducive to whatever they say?
Says I'm making plans in my head.
Okay, all right. So that will be common for all parents, okay? Or even if you're single, for instance, you're because this will disrupt everything, right? So this will change your plans, like, oh, I have an exam next week. I guess that's not happening. Or let's say, oh, I have a date next week, or I'm getting married. So that will put a hold on all your plans, correct? And I'm sure you know someone, or you know, this topic may hit close to home for some of you. May have experience personally within your family, or with any of your friends or significant others that have been affected by cancer in one way or another. So it's not just us, right? So let's say your friends, how will they react once you have a diagnosis of cancer? All right, so it's not just so it's a big it's a big challenge to face, not just the patient, but also for the nurses, the caregivers as well. So let's start with, how do we get cancer? If you read the pathophysiology section, I'll just summarize it. We have at some point characteristics of cancer, particularly in the fetal development stage, more so specifically in the embryonic period. So imagine when Brianna was conceived, you were one cell, correct? You were one egg, a single cell organism. And then your mom said to your dad, sup? And then dad said, sup? And then long story short, you were conceived. Okay. So from one cell, you became two, and then four, and then 8 and 16, etc. So that happened really quickly, right? In a matter of seconds, you became from one cell to now a complex embryo. Now imagine the rate of cell division happening there. And it changes one cell, right? And then how can one cell become a human body? Okay, so if you think about it, there's some cancer characteristics there, correct? I mean, cells mutated, changed, one stem cell, for instance, became all these organs, a complex organ of the brain, the heart, 2 kidneys, 2 lungs. So you can see how a human embryo really has the characteristics of cancer during that period, correct? Because what are the characteristics of cancer? So let's describe it here. Okay, so we'll compare benign and malignant tumors. So both of them have a characteristic of rapid cell division. So let's go straight to the table 12-1. I would have appreciated if there was one more column that shows normal cell characteristics, so that we can see from normal to benign to malignant. Okay, but because they just comparing to. Okay, so benign cells actually resemble normal cells with a few exceptions, and I'll point them out as we go row by row. So let's start with the cell. Benign cells are like normal cells. They are well differentiated. When we say well differentiated, meaning it's a distinct feature. I mean, there's a distinct shape of the of the cell, and it resembles normal cells. Okay, you can't really tell them apart. Whereas malignant cells, it's undifferentiated, meaning they can vary in shape depending on which organ they're growing in. And in fact, they bear little resemblance to the normal cells where they grow, meaning you can easily identify them, making them good targets for immunotherapy. Immunotherapy works by using your immune system, your white blood cells, to kill cancer cells, meaning we arm them. We make your white blood cells more powerful in order to identify and kill cancer cells. But they only work in malignant cells, though, because your benign cells, as described here, they resemble normal cells. So can the white blood cells distinguish between normal and benign cancer cells? That's the challenge with immunotherapy. But it works very well with malignant cancer because they are completely different. They look foreign, so they're very good targets for immunotherapy. Mode of growth. Grows by expansion. However, cannot infiltrate surrounding tissues, meaning they resemble normal cells. However, the rate of growth is way higher, way faster compared to normal cells. And in the case of malignant cells, they do not have a limit, meaning benign tumors cannot expand. They will crowd the organ where they're growing in, but they cannot invade an adjacent organ. Meaning, if you have a benign tumor in your breast, it cannot enter the bloodstream, it cannot enter lymph nodes, it cannot spread to your heart. That's what the mode of growth description means. Whereas in the malignant cells, they have no limit. They are not limited to the body system where they're growing. They can enter lymphatic circulation, arterial circulation, and then spread wherever they want. Okay, so they can enter lymph nodes, use that as a highway to spread to other body systems. Rate of growth. This one usually slow, but still faster compared to normal cells. However, this one in malignant, really, really fast. And there's no limit again. Unlike normal cells wherein we have contact inhibition. So you'll notice a scar, right? After you get a wound, it was open for a while, and then after a couple weeks, it completely healed, right? Replaced by scar tissue. And then you notice the scar tissue did not go beyond the border. That's because they have something called contact inhibition. So normal cells, once they hit a wall, they stop growing. That is their cue that, oh, I hit something. I can't grow anymore. I'll stop dividing right here because I already hit something. So that's contact inhibition. So there's also the same contact inhibition in benign cells. However, in malignant, there is no contact inhibition. If they hit a wall, they'll push against that wall and then go beyond the body system. All right, there's no limit, there's no contact inhibition in malignant cells. Metastasis, because the benign cells have contact inhibition, therefore, and they cannot enter blood vessels or spread to lymphatic system, they therefore cannot spread. They stay where they're growing. Not so in the case of malignant cells. Malignant cells go beyond their original body system where they're growing, and there's no limit as to how many places they can go. I'll skip the next two. They're not really that significant. Let's go to the last row. Ability to cause death. Now, this doesn't mean, notice that the word used is does not usually cause death. It really depends on the location. For instance, if I have a tumor in my abdomen, can my abdomen grow infinitely? Yes, because yes. Yeah. So if I'm going, look at mine, okay? So I have like 3 tumors here. So it can grow and it can expand, and depending on the location. So I have plenty of room in my abdominal cavity. However, put the same tumor in my skull. Can my skull expand?
No.
So that's the point they're saying here. So depending on the location. So if the location is restrictive, then it can kill the patient. Okay, so that's the only case wherein the benign cells can kill you. Okay, so it's not true that you have a benign cell, oh, that's good, it's treatable, it can't kill me. Well, it depends. Where is the benign tumor located? Of course, in malignant cells, because they can spread to up to 5 or 6 different locations, then of course it will cause death. It will cause a lot of pain because the fact that they have no differentiation here, when we say undifferentiated, that cell therefore serves no physiologic purpose. They're there eating oxygen, eating nutrients, but not giving any benefit to the body. Not so in benign tumors. Benign tumors still perform a function. They're just extra growing, all right? But not so in malignant. They grow fast, they eat a lot, and they rob the body of nutrition, of vital nutrients. So let's go to how did we get here? Now, remember, I mentioned to you that we have cancer characteristics, correct? So all humans do at some point in our lives, we had these characteristics of rapid cellular growth and division. When we talk about carcinogenesis, this is how does this part is not testable. I'm just trying to explain how a cancer cell develops. Now, we have, I'll just describe it as in a car, a gas pedal and a brake pedal. So gas pedal, when you step on it, makes you run fast, right? So that will be compared to at some point during your embryonic development, we needed these, how do I call it? Maybe there's a term here. Not really. Okay, I'll just call them oncogenes. Okay. So we had oncogenes. Oncogenes, as described here, are responsible for vital cell functions, including proliferation and differentiation. So proliferation is what? Cell division, correct? And then differentiation is acquiring is a specific function for that cell. So that's what oncogenes are. So we needed that. So the oncogenes, think of it as the gas pedal, the accelerator. Now we need also a brake pedal. The brake pedal will be called suppressor genes. Okay, so we have oncogenes, which is the gas, and then we have the suppressor genes, which are the brake. Okay, to stop it at some point. It has to stop at some point. Let's say after your first year, it should stop, because you notice also during our first year of life, we triple our height, right? We double our weight. Okay, so that's how fast. So we still have that rapid growth characteristic during our first year. But after that, it should start slowing down. So we have the capability of making cancer, but we won't develop cancer unless we are exposed to carcinogens. Now, there are many carcinogens though. We have chemical carcinogens, we have viral carcinogens, we have medications, we have other substances, tobacco, for instance, and certain diseases. So they cause cancer, right? Let's say hepatitis causes liver cancer, right? Or let's say you've heard of HPV causing anal cancer and oral cancer also. Okay, so these are what we mean by unless you're exposed to our carcinogen, you won't develop cancer. Does that make sense? Okay. So we still need exposure to the carcinogen in order to develop a certain type of cancer. So let's name a few carcinogens. Viruses and bacteria, and they give examples here. Epstein-Barr, I mentioned HPV. Other viruses are, of course, the hepatitis virus. What about the hepatitis B? Yeah, that's another virus that's known to cause liver cancer as well. And here are a few more bacteria in the stomach. H. pylori. Remember this from peptic ulcer? Okay. Then we've got physical agents. So there's unlimited here. California has the longest list. So we'll start with the sun, UV rays from the sun. Smoking doesn't really, it's not limited to tobacco. It could be also cigars. Then we've got other certain chemicals and asbestos. What is the cancer linked to asbestos? Mesothelioma. And then we have genetics. We have, we can screen for genetic predisposition for cancer, but the problem with this here, the challenge here is even if you're positive for the genes, doesn't really mean you're going to develop the cancer. You've heard of Angelina Jolie, right? So she tested positive, and what did she do? Because she had money, she had her, yeah, she had a mastectomy and then got new ones.
Because she had money.
Yes, the rest of us are, I mean, our insurance is not going to cover that because you don't have cancer. So they'll only do that if you have evidence, yeah, of actual cancer.
I don't wanna.
Well, it depends on the type and, you know, the type of work that's gonna be done.
So
You
if
may change your
remove
mind.
it, would it give you like a lesser chance of getting cancer?
It's not 100% either.
You still may get some.
I mean, we don't know, you know, you never know the reason for people.
I was just thinking it out.
So we have chemicals that cause cancer. Alright, so how is table 12-2 tested? Very simple. When we say carcinoma or sarcoma, those are really malignant tumors.
Yeah.
Here, carcinoma, sarcoma, or blastoma in the case. Well, it has to be like carcinoma, sarcoma. However, other omas, if it's just an oma, not carci, not sarco, just the oma, they are generally benign, except myeloma. And also, what's the skin cancer? Melanoma. Okay, so that's another exception because it's an oma. However, there is no benign form of
Yeah.
melanoma. They're all malignant. The same thing also for multiple myeloma.
So carcinoma is malignant, right?
Yeah, sarcoma. So anything that ends in sarcoma. Because how they invent, you remember medical terminology? So there's a root, there's a prefix, and then there's a suffix, right? So that's how they construct a medical term, right? So if the suffix is carcinoma or sarcoma or blastoma, those are all malignant. Because how they construct it is the prefix is always the tissue of origin. For instance, look at this word here, adenocarcinoma. So the prefix is adeno, which is an endocrine, an endocrine gland, like the adrenal, for instance, okay, or let's say the pituitary gland. Okay, so they're referring to those. And here, osteo, this is referring to bone. Okay,
I know that's.
right, lipo, etc. Right, you get the idea. Right. So how is this tested? Now, the question I posed to you at the start with Miss Chioma, for instance. So since Miss Chioma's concerned at that point, because is she grieving at that point when she was giving the? She's not grieving. She is. Yeah, we call that anticipatory grieving, right? So she was already thinking, oh, I'm gonna die. Okay, that's what she associated cancer with. So therefore, what stage of grief was she in? At that point, when the doctor told her, okay, so still denial, anger, correct? So is she gonna be susceptible, or is she receptive to all the teaching and explanation the doctor will give? No. So do we know when she's gonna go through the acceptance stage? Who is gonna be around when she finally gets to the acceptance stage? Let's say she's still in the hospital. Who's gonna be around? The nurses are gonna be there. So that's why we have to be prepared, correct? So we have to grab that, right? We have to grab the opportunity when she's in the acceptance stage. Right, we are ready to educate. So let's say at the acceptance stage, and then she was doing the research, and then she said, for instance, she was given a diagnosis of osteosarcoma. Right, and then she said, oh, I'm so glad this is benign. Yeah, I thought I was gonna die, and here I am, you know, blah blah blah. And then there you are, you heard her say that. What are you gonna say?
I'm gonna say no.
That's what you think. Is that gonna you say? No, you're gonna say, okay, let's talk about your diagnosis, right?
Yeah.
Right. Okay, so that way you provide education, so you provide realistic outcome for her. Okay, so that she's aware of what she's dealing with. So here are a few more examples of carcinogens, chemicals again, substances, and we already talked about the genetics. Again, what did we say about genetics? Is it guaranteed that you will? Okay. but it does have your increase your risk. Okay, allows the patient to be more conscious. Right, we'll get to the prevention shortly. And then lifestyle, too much alcohol, and then smoking definitely. With alcohol, it's only too much. Okay, too much alcohol. Yes, that's fine. And hormonal agents as well. So you've heard of testosterone supplements, for instance, okay, or other female hormones. All right. And the immune system. So what type of cancer do AIDS patients get? The skin cancer that
Myeloma, right? Melanoma.
Kaposi sarcoma. So that's right. The one that makes them look like a leopard.
Oh, yeah, with the spot.
Right. Okay. So that's one proof that our immune system fights cancer. So that's why AIDS patients develop Kaposi sarcoma, because they have less white blood cells to target the causative organism. All right, let's go now to prevention. There are two levels of prevention. There's actually a tertiary mentioned here, but tertiary refers to cancer survivors only, meaning after a person gets cancer, gets treatment, and survives the cancer, and then they institute prevention aimed at preventing the recurrence of cancer. That's what we call tertiary. But let's focus on primary and secondary. Primary, as you described the first statement, it's about what? Reducing the risk. So what are examples of primary prevention, therefore? If you're avoiding the risk, do you have the risk here at this level? Not yet. You're avoiding or reducing the risk. So what would be examples here? Stop smoking, or if you don't smoke, don't start. Right, reduce alcohol, use sunscreen. Okay, so those are all primary. You're trying to avoid the risk factor. Let's say you eat only steak once a month, for instance, right? Or let's say you get immunizations. Okay, those are all primary prevention. So you're trying to prevent the or avoid, sorry, you're trying to avoid or reduce the risk factor. Secondary prevention, what does it involve now? Screening and early detection. Okay, so screening and early detection fall under secondary. So what are the examples? So let's go now to the website. So when you type in cancer.org, the website changes, by the way, each time. So it will not look like this. But just go down the list. I'll show you where to get it. Yes.
So I had a patient come out my OR. They removed the old ovary, right? And she had HPV and she was ever to cervical. That they still gave her the HPV vaccine, but what she already had.
Doesn't mean it's not, you don't develop immunity against cancer. Does that make sense?
Oh, okay. It's just to help prevent any.
Yes.
Okay.
Okay, so let's go to, it should say something like early detection, right here, get screened.
It's not on the,
Oh. Yeah, I'll repeat it. All right, so I typed cancer.org. This is the website. Just scroll down and find something that says screening right here, get screened. And then let's go to cancer screening recommendations.
Well, I don't like this computer now.
So after you clicked on screening, let me start over. Okay, cancer.org. And then go to get screened right here. Click on get screened. think it's the weather. Okay, go to cancer screening recommendations. And then you can go either with age, screening guidelines by age, or you can also go with
What screen is this? Phone. Okay. Can I ask you something? How come they didn't lower the age of the colon
Yeah.
for the? men?
askcancer.org.
Right.
So the American Cancer Society, of course, is our national authority on cancer. Why? Because they gather all cancer statistics. So they will publish a report every April, the previous year. So now it's 2023, so the 2022 statistics should be ready online, published as of April. So why do they publish the information? Well, if let's say this is the recommendation, look at under cancer. When we say breast cancer screening recommended beginning age 45 with the option to begin at 40, what will the insurance company do?
C is the reason why.
If you are 38,
Like if you have 5 or 6.
will they pay for your screening?
Unless your doctor has a good reason.
Will they pay for your screening if you're 38? No. Take into consideration though that this recommendation here is only for average risk for cancer. Average risk of cancer. If you, however, have symptoms, let's say you have a lump and you're only 21. You're only 21. Are you at average risk? No more. You're at a higher risk for cancer. So now you will have your insurance company paying for you. What is all these again for? Average risk of cancer. Yes.
So when they say like if you have like a family background of like breast cancer and they tell you to come in earlier than like 45, 40, the insurance company's still not gonna pay for it or?
Again, average, this is only for average risk of
Basically,
cancer.
You're not average then.
You're
You
not
have it.
average.
You see some symptoms.
Correct. All right. So look at this here. Let's start with cervical cancer. Let's go to cancer screening by age. It will be more specific.
And again, it's
Okay, so 21, we will only test 3. I will only test cervical, breast, and colorectal cancer.
Okay.
That's women's,
No. Yeah. So let's start with 21 to 29.
21.
So there's no, as you can see, nothing here, right? Nothing for colon cancer, nothing for breast, but there is for cervical cancer. Starting at age what? 25 through 35. So this is the guidelines. So if you're 25, doesn't really matter if you're, let's say you have, if you have, you're sexually active from age 18. Okay, so it's not recommended that you have screening. Yes. Are you listening?
Yeah.
All right. So when does cancer screening involves a pap smear?
Yeah.
Okay. So starts at age 25. Even if you're sexually active at 13, you still do not have early detection for cervical cancer because the recommendation is age 25. Okay. So this is what I mean by it changes. So in 2008, when I first looked at this, it said all sexually active women must be screened. Right, they keep changing. A few years ago, it said 21. Now it says 25. So these recommendations change according to evidence. Okay, so as new evidence comes, then they change the recommendations. Are we clear?
Yeah.
So that's for cervical cancer. Now let's go to, I'll skip over 3039 because there's really nothing there. See, none.
Okay.
Let's go to accept cervical. It just says here continue. Okay. 40 to 49, again, there's colon cancer here now, because for colon cancer, it starts at 45. Used to be, this was 50. And then about 10 years ago, it said 55. So the colon cancer risk is now getting younger and younger. So now we're starting at 45. Now you'll see the recommendation is better now because a few years ago, 2016, before 2016, it still said a colonoscopy. Now, no more. It just says a stool-based exam. You've seen the commercial of Cologuard, right? Okay, so they can detect colon cancer now based on your fecal sample. Okay?
The same thing as a guaiac or no?
Now, guaiac is to detect blood. Yeah. So, a stool-based exam is all that it takes. So it's very
Just send it.
convenient. Yeah, just send it in by mail or go to a lab. Okay, give them a stool sample. That's it. If it's positive, then you will be sent for a colonoscopy. Okay, so now it's very convenient. So it's now good for everybody because all you need is a stool sample. Okay, you don't have to prep the inconvenience of NPO and then clear liquid, taking the laxatives. So it's a hassle to get a colonoscopy. Plus you get sedated and then you can't drive home. Now it's very easy. You can do it from your home, mail it in. Breast cancer starts at 40. So at 45 though, they said, look at the verb used, said should get a mammogram at 45. At 40, only if the patient wishes to do so. So it's an option from 40 to 44. However, 45, it's highly recommended that you should get one. So your doctor will start scolding you. You go to your primary care physician, you're 50 years old, you never had a mammogram, you will be scolded by your primary provider. I know this has been around for a while. I'd say 10 years. It was the same recommendation. That's about it for cancer screening. So we covered the, right. So therefore, back here, what was the patient's risk that we are talking about here? So what is the single most important risk factor for cancer? What was common between colorectal, breast, and cervical cancer screening? What was the Jason? The age, right? Age, therefore, is the single most important risk factor for cancer. If you reach a certain age, you become susceptible to cancer. Let's go to diagnosis now. There are some things we...
And we also have to read tertiary, right?
Like I said, tertiary prevention is like prevention methods testing only for cancer survivors.
Oh, okay.
Are you gonna test us on anything from that website?
Yeah, he does the screenings.
So how do we diagnose the cancer? Okay, so patients suspected with cancer undergo extensive testing. Why? We need to stage it, grade and stage the cancer. Next, identify whether or not it is malignant or benign. Third, if it is malignant, where has it spread to? And then finally, identify the organism, the type of cancer by getting a biopsy. So therefore, what's the only definite diagnostic testing for cancer? A biopsy. You have to get a sample of that tissue and then see what it is, what we're dealing with, and proceed with the either further testing to find the possible spread or metastasis, or to identify what it is susceptible to, meaning what is the best way to treat your particular type of cancer. For tumor staging and grading, we will only test the staging part. So here's the guidelines. I don't know if they're accurate. That's why I brought you to cancer.org, but I'm not sure. Again, I didn't read table 12-3 lately, because if you have an ebook, it automatically updates as well. So I don't know if they updated the table lately. I would still recommend the website, because look at this cervix. Is it accurate? No. The website said 25. This one is still 21. This is not accurate anymore. Right. So this is what I mean. Okay. So use cancer.org because it is the most up-to-date information. Colorectal is correct though, 45. The reason I didn't do the others is they're pretty simple. Let's say for lung cancer, the only screening is a CAT scan. For prostate, it's only one blood test, which is a PSA.
You have to remember those two?
No, I mean, they're not. I mean, it's easy. I just told you.
Oh.
Okay, so tumor markers. Now, take note that what does this table say? Does it say to diagnose cancer?
No.
No. What did the other table say? Used to? Right. So therefore, no, sorry. The where's the other one? Okay, right here. So our only definite diagnostic test will be the biopsy. Okay. So table 12-4 only used to help detect cancer. Is it used to diagnose cancer? No. The reason is these tumor markers are not exclusively found in cancer. They are not exclusively found in cancer. For instance, when we say CA-125, this is a tumor marker, CA-125 test. So this one is used to monitor and help diagnose cancer. For instance, if you look at CA-125, what is it used for? What type of cancer? Ovarian. Ovarian cancer, meaning
What's the difference between being able to detect it and diagnose?
I'm trying to get there. Okay. So CA-125 is a tumor marker, meaning these are elevated when the patient has ovarian cancer. However, it's also elevated in non-cancerous conditions. Liver disease can cause your CA-125 level to rise. You see what I mean?
Yeah.
Is it exclusively found in cancer? No. So does that answer your question, Jessica?
Yeah.
Okay. So we cannot use it to diagnose cancer. However, can it help us though? Yes, but can we use it to diagnose cancer? No. You know how the payment scheme now for insurance companies has changed? Before a doctor can order a CAT scan, they have to justify, because these are very expensive tests. And of course, the hospital wants to make sure that they get reimbursed, correct? So before a doctor orders a CAT scan, he must justify why you're ordering it, because there's a chance we may not get paid by the insurance company. We run all these tests and not get reimbursement. One of those is for cancer. So before a doctor goes and gets a ultrasound or a CAT scan or MRI of the pelvis, what must the doctor order? A CA-125. So let's say a doctor, a gynecologist suspects, oh, these symptoms look like ovarian cancer. Okay, so let's run a blood test first, and then the doctor orders the blood test. And if the CA-125 is high, then can the doctor order the CAT scan or the MRI? Yes. So now he has right, it's justified. See, yeah. I have a high CA-125, patient has these symptoms, I would like an MRI, please. So of course, the insurance will say, okay, here's your authorization. Okay, everybody gets paid. So that's so therefore, what statement can you say about tumor markers? What is their purpose therefore?
Used to detect cancer.
Okay, help detect cancer. And also, can we use the same also to monitor response to treatment?
Yeah.
Yes.
Yes, because when we start treating the patient,
The levels will go
the
down.
levels will go down. So if the levels go down, is the treatment effective?
Working.
Yeah.
What if the level remains the same or goes up?
It's not
It's
working.
not.
Very good. So that's the same also for genetic tumor markers. Mammography, of course, gives you a visual evidence of the tumor. We have modern, for those who are wary about having a mammogram, it's modern now. We have 3D mammos, so you don't have to do the traditional wherein they make a panini out of your breast. You know, those, I mean, those are still around, but there are modern mammograms now. These are just nice to know. So just look at how right, so these are the different tests. Now for detecting metastasis, so let's say after a biopsy, a tumor, according to the oncologist, looks like a very malignant type of tumor, highly metastatic. So now they will order a PET scan. So this will be a whole body scan, detecting for any possible tumors. So if they see it in your bone, whichever bone, the leg, the spine, or the arm, for instance, so they will see it. Okay, so this test will slice your body into millions of pieces, so they can see where the tumors are possibly found. TNM classification. There are 3 in the acronym here. We have tumor, lymph node, and metastasis. So this is staging classification. This is universal. Whichever country you go to, they'll use the same classification for staging. T, I already said T is the whether or not there's a primary tumor, there's a tumor. N is whether or not there are lymph nodes involved. Metastasis indicates whether or not there is spread. And then it will also determine how many has it spread to. With the T, it can be TX, T0, TIS, or T1, 2, 3, and 4. TX means we don't know. There's not enough evidence to say whether or not there is a tumor. We don't know if there is a tumor. We also can't say that there's no tumor. Does that make sense? Okay, so therefore, obviously, we need further testing. T0 is good because we know there's evidence that there is no tumor. Okay, we know that there's no evidence of a tumor.
So if there's no tumor, there's no cancer.
T0.
T0.
So T0 means no cancer.
No tumor. That's all it's saying though. No tumor.
So the TX is the tumor is there.
No. TX, we have no idea.
Okay.
We need further testing. We're not sure. Yeah, they see something, but they're not sure. I don't think that's a tumor. Okay? It could be a feces or whatever, right? They're not sure.
That's when they did.
Yeah, CAT scan or MRI. Okay. TIS, there is a tumor, but it's in situ. When it says in situ, it is stationary, meaning it's usually encapsulated in something. Therefore, TIS, is that benign or malignant? Benign because it's in situ. Right. Now,
Wait,
T1,
TIS means it's benign.
because it's it's in situ, meaning it's encapsulated in something.
Because if the lymph spread benign.
Okay, T1, 2, 3, and 4 is subjective. This indicates the size of the tumor. However, they don't have a range as in that would make T1 a tumor T1 because let's say let's just put it this way. T1 is small, T2 is medium, T3 is large, T4 is extra large. A T1 tumor in the colon, is it the same size as a T1 in the brain?
No.
No, that's what I mean. This becomes subjective, yes?
Is it because of the size of the organ?
The location, correct, right? So in relative to the brain and the abdominal cavity, will the tumors T1 and T4 be the same size?
No.
No. So you understand? So the doctor will just describe it as T1, T2, but that's your idea that if it's T1, it's small. T3, that's quite big. T4, that's huge, yes.
So would that mean that a T4 in the brain could be like a T1 in the abdomen based on the size?
Maybe a T2, yeah, something like that, right? Because, you can just put it there like this,
Yeah.
okay? But don't worry, the doctor does this. But all your role here is to help explain it to the patient. Remember what I did with Miss Chioma earlier? So later, when she asks you questions, will it be proper to say, oh, it's better that you talk to your doctor about this? Will you pass the buck? No, give the answer right there. Okay, so take the opportunity that she is receptive to the teaching. Lymph nodes, NX, we don't know. N0, this is good. We're sure that there is no lymph node involvement. And then this one, there's no limit to the number. This can go to N6 and 7. Literally, how many lymph nodes are involved? Okay. Right. And then 2, 3, and then 4, 5. Now let's go to this metastasis. MX, again, we don't know. X is no idea. We're not sure. M0, good. There's no spread. And then this one can also be M1, M2, M3, M4, M5. Yes. How many body systems has it spread to? How many organs?
Question. So they would say like CXNOMX, like they would put them all together.
Okay, let me give you an example. Let's say the patient's cancer is a staging, according to the doctor, is T1 N0 MX. How do you interpret that? T1 N0 MX.
Extra small.
A small tumor, N0, no lymph node involvement, and no, I said MX.
We don't know if it's metastatic.
Easy, right?
No, can I just ask you one more question? I know I'm being annoying.
Very.
Are you gonna put something like that on the exam, like T?
Exactly, the example I gave you, yes. Yes, all right. So that's for staging. By the way, with metastasis, so let's say, when it says, I'll give you another example. T3, N1, and M4. T3, N1, M4. T3, M1, N1, M4.
Three tumors found in bodies.
No, a large tumor, right? T3. And then N1,
One lymph node.
one lymph node. Then M4.
Just four organs.
Okay.
That's the size of the four.
Okay, let me ask you. Very good. Let me ask you. How many cancers does the patient have?
One.
No, 4. Wait,
Four.
Wait a minute. One lymph node is involved.
Okay, let me repeat. Okay. T3, N1, M4. How many cancers does the patient have?
Four.
Why did you say 4?
Because there's 4 different types of
Don't you have one
metastases.
cancer?
It's the same cancer. that has spread to 4 different parts of the organ. That makes sense? The patient has one cancer
It just metastasized to 4 different areas.
spread to 4 different parts of the body.
But they're newly diagnosed and they found that it was metastasized in different places. What tells them that it was originally what kind of?
Okay, very good question. So what they'll do is get a, how do we diagnose cancer again?
Biopsy
Okay, so they'll get a biopsy from each tumor.
and tested.
So they'll get biopsies from all those metastatic, well, we don't know really. So we found 4 tumors, right? In different parts of the body. We'll get a sample for each one. So what will the microscope show? The same cell. All of those, right? You got them from your breast, from your lung, from your bone, from your testicle. We put them in the microscope. We saw the same thing. They look the same.
Are you able to know where it started?
Yeah, how you go back so?
Okay, I'll answer that. So if the tissue looks like a specific organ, so let's say we got a breast, lung, liver, and bone metastasis, spine, okay? All of them look like liver tissue.
Oh.
So they took a biopsy.
So which one is the primary tumor? The liver. The liver tumor is the primary one,
Because it replicates that.
right? Because it resembles where they were found. Okay, yes.
So is it possible then to have like, multiple?
You can have multiple,
Like, not what you're saying, like, I know it metastasizes and then it's, okay.
Correct.
What is one type, but like, can you say like, you have, leukemia and breast cancer like that?
correct. So let's say Woodruff is asking, how do you know that they have multiple tumor cancers instead of one? Well, if the tumor biopsies look different, how many types of cancer this patient has? So they're different tumors, they're different cancers. Okay,
So they look the same as one if they look different.
exactly. Right.
Just to be clear, metastasize is just literally the spreading of the same tissue.
The same
from the
cancer, right.
original tumor.
Mhm. Yes.
Alright, so like for instance, my grandmother had breast cancer and then she beat that and then she got leukemia. So is it possible or?
By the way, what treatment did you have? Radiation or
It kills your
chemo?
white blood
I
cells, right?
Radiation?
I think she did, with the breast she had.
Okay, the problem with the cancer treatment, which we'll discuss shortly, yeah, it causes other cancers, especially radiation. Right. I mean, they won't get it now, but they'll get it later.
Yeah.
Be- right. Because if you notice under the carcinogenesis, right here in this section, one of the substances mentioned here is radiation. You know, remember UV rays of the sun? So any radiation, it's not just the sun. So it's any, whether it's radiation from the sun or radiation from X-ray or radiation for chemo, for cancer.
It was the treatment.
No.
It's the treatment that caused it.
What did you say? Treatment cost.
All right, let's go.
Affect people like that.
Sorry.
Why do they still use radiation if they know that?
It's effective though, and it doesn't cause cancer in all patients.
Yeah.
You know how when you do surgery, you know, they have you sign consent. Same thing, when you receive treatment for cancer, one of the disclaimers is, of course, yeah, you're already informed that this could cause more cancers in the future. Yeah. Yes.
Usually they have a cure for cancer, they just hide it. I have been very.
All right, let's go to the all right,
Yeah, but you got-
management. So what is our discussion gonna be on again? Surgery, chemo, and radiation only. All right. Now, there are different purposes for treatment. The treatment can be aimed at cure. It can also be aimed at palliation. What is palliation?
Palliative care.
Okay,
reduce
only to,
symptoms.
right, so for comfort, right? Yeah, reduce pain, improve the appearance. That's for palliation, or to restore function. It could also be rehabilitative, or it could also be debulking, just reducing the tumor. Okay, so there are different types of, goals for treating cancer. Of course, all of us want to cure it, right? but there are cancers that are not curable. So that's why we have different purposes for, it's not gonna be discussed in this chapter. Okay? Again, that's not a nursing concern anyway. So the only ones we'll do are surgery, radiation, and chemo. We won't do stem cell therapy or immunotherapy or targeted therapy. Are we clear? Okay, so only 3.
Because it's expensive.
Where did you?
Yeah, it's out of reach for the common Common American. Okay, surgery is the oldest form of treating cancer. It's been around for centuries.
Remove.
Right, so we remove, again, there are many purposes of surgery. It can be curative. It can also be preventive. An example of prophylactic surgery is, what did Angelina Jolie do? Mastectomy. Okay. Another example is, you've heard of polyps.
Yeah.
Okay, so when you have colon polyps, they're not cancer, but they've been known to possibly turn into cancer. So that's another example of prophylactic surgery. And of course, I gave you examples of palliative. Let's say there's a patient who has incurable brain tumor, but they cannot remove it totally. Can we just remove part of it though? Yes. So that would be to decrease the frequency of seizures, for instance, to eliminate pain, okay? Or eliminate headaches, for instance. So that's the purpose of, or that's an example of palliative. Reconstructive, so let's say you lost the entire breast as well as the areola and the nipples. So we can make you new ones, okay? So we can make, we can make you a new nipple, a new areola, okay? Restore.
Call it deep. or
I don't know, I haven't made one, but they can't do that now. I'll tell you when I get one.
something.
Okay? I'm planning. So there's a diagnostic. So biopsy is a form of surgery. Okay, so diagnostic purposes. I won't go into details about biopsy types.
Diagnostic.
So surgery as primary treatment, definitely this is for curative purposes. Or it can also be, as I mentioned earlier, a bit earlier, debulking, reduce the size of the tumor, which doesn't really mean cure. Okay, it's just reducing the size of it. It could be used for palliative purposes. And here are different ways to do surgery. So you've heard of modern treatments, bloodless surgery. Have you heard of that? Okay, so that really is referring to no, radiation. So yeah, they have CyberKnife. Have you heard of CyberKnife? Okay, so CyberKnife is not literally a knife, but it's radiation,
Directly to.
right? Used to surgically, with surgical precision, to target the tumor, okay, with less side effects. So we got laser, electrosurgery, or radio frequency. So these are not all using scalpels, okay? These are examples. I'm not testing these. This is just nice to know. This one, this is just nice to know, table 12-6. So for prophylaxis, I gave you examples already. Palliative, I gave you examples as well. Reconstructive as well. So what is the nurse's role with patients receiving surgery for cancer? Is it any different from the post-op care we talked about for exam 1?
No.
Same. What are the side effects of surgery? Same as we talked about, so same. However, the consequences here, of course, will be, in the first place, what can we remove? Vital or non-vital organs? Okay, so we can only obviously remove non-vital organs. So the consequences will depend. So let's say you lost your larynx due to laryngeal cancer. What will you have now? A tracheostomy. Let's say you lost your You lost your esophagus.
Commercial your whole life.
What will you have? You have no more esophagus, a feeding tube. You lost a huge chunk of your colon. What will you have? An ileostomy. Okay.
Yeah.
So and so forth. So really depends on what was done. And then that will be the consequence of the surgery. Does that make sense? Of course, you lost your leg, then now you're an amputee, right? So you lost your arm, and etc.
Because your lungs are vital, right? And sometimes they move like a lobe.
Correct. So we have how many lobes on the right? Three.
Three.
How many on the left?
Two.
Two. So you can remove one or two lobes.
Okay.
Because the remaining lobes will just expand. Meaning,
Oh.
let's say you have three here, right?
Yeah,
The size of the lobe is only determined because there's no other space.
right.
But if you remove one, of course, that one lobe can expand.
Oh, okay.
That makes sense?
Yes.
Okay.
Okay.
Right. It's just because there are three here. So that's why it's that size. But if you remove one, of course, it will fill the available space. Right. Like when you're sitting on the train, right? So you're sitting like this because it's so
And then
crowded,
the
but
person who wants to
Right.
Right here.
again, the complications are the same as with the post-op chapter. As you can see here, it will be the same. We have pressure ulcers, dehiscence, evisceration, infection, DVTs, pneumonia, etc. Okay, same post-op complications. Radiation. First of all, there are two types of radiation. We have external and internal radiation. In internal radiation, we have sealed and unsealed. Let's start with the external radiation first. There are many names used when we say external radiation. It could be external beam therapy. It's also electromagnetic radiation. There are many names used to it, but they have one thing in common. The source of the radiation is outside. Let's say you go to Memorial Sloan Kettering. You get treatment, you get radiation treatment. There's a room. Let's say this is the treatment room. So there's a bed here, and you'll be placed on the bed. And with repeated, let's say you go there 3 times a week or once every week for 7 weeks, however the frequency is. The radiation, of course, works by 3 ways. There are 3 elements involved. So there's time, distance, and shielding. So time is how long were you exposed to radiation? Distance, how far were you from the radiation source? So those 2 things determine how much radiation your body will absorb. How it works is right here. So we're using particulate radiation, harmful particulates, and they will kill cells. However, can they kill only tumor cells? They will kill anything that is exposed to it. So therefore, some cancer cells as well as normal cells will die today upon exposure. However, because your body absorbed it, some will die later. When you go home, more will die. Tomorrow, more will die, etc. So that's the concept of radiation therapy. However, since the source is outside, do you carry the radiation with you when you go home? No. No. Your cells were exposed. They're only inside your cells. It will kill those cells eventually, right? But did you bring the radiation source with you? Did you put it in your bag and then go home? No. It's in the treatment center. So when you go home, there's no precautions needed. Okay, you are not radioactive. So that's why if you work in radiation oncology, or let's say here you've had x-rays, what did the radiation technician do while they exposed you? And they hid behind a room, right? Right. So therefore, they don't want to be exposed. Or if they have to be near you, they have to wear a lead apron. Any question on external radiation? All right. I already explained the EBRM, that external beam radiation. Okay. The dose again is determined by the time and duration of exposure.
Should we know the dose?
I know.
You don't have to.
So here's, it's EBRT, sorry, external beam radiation therapy. Okay, so that's external radiation. Again, the patient is not radioactive here. You can go home. You're okay. As far as your family is concerned. So 1 to 5 treatment days, 5 days a week. It varies, okay, depending on the type of cancer you have. Let's go to internal radiation. Yes.
With the people that are radiation, with all of them.
No, for external radiation therapy, no, there's no precaution. Internal radiation, however, is different. So it's also called brachytherapy. Brachy means near, so the treatment is near. In fact, it's inside the patient. Okay, so we have two forms, two types of internal radiation. It's either sealed or unsealed. One way for sealed radiations are, it has some container, some membrane, some pouch, some applicator. For example, you all have eaten edible arrangements, correct?
No.
But you know what edible arrangements are? Okay. So we have sticks, correct? And then we have the fruits, cantaloupe, pineapples, strawberries at the tip. So think of it that way. So brachytherapy can be applied using applicators. So you have sticks, literally plastic sticks, and they have radiation seeds at the tip. And they will bunch them up together, tie it with a rubber band, and then stick it into a body cavity. Usually with applicators like that, they put it up into the breast. So after surgery, for instance, so there's a void, correct? Where they remove the tumor or the lump. So the space left there by the tumor, wherever the lump was, is kept open, meaning the incision is not closed, and then they'll stick the applicators with a bunch of those radiation rods or seeds at the tip, and then tape it. After every few days, they will take it out and then replace it with another one. Meaning these radiation seeds are radioactive only for a while. Now, what does the patient do when they go home? They have the radiation inside their body. Are they radioactive?
Yes.
Yes. So let's talk about the distance. If it's external, okay, let's start with external sealed radiation. Those with applicators. They can also be inserted into the bladder, into the uterus. You familiar with intrauterine devices? The one with the string that you can, take it back out. Okay, so it can be, applicators can be like that. So the oncologist will implant the radiation seeds into the uterus, and then the string comes out of the cervix, and then they'll use that to retrieve it later. All right, so things like that, they can put it in almost any body cavity. Okay, they have ingenious ways of using applicators in order, and also for them to remove them at a later time. Some, however, are so small that they may be left in the body cavity forever, and your body will just absorb it, your macrophages, meaning they're that tiny. Example of that are prostate radiation seeds. So those are so small, they're injected into the prostate, but they're left alone. There's no way to retrieve it because they're so tiny. Your body will just eat up those particles. All right. Sealed internal radiation.
Which is brachytherapy.
So many questions in the API.
Right. So let's talk about the precautions. So it's sealed, correct? So there's a covering, there's a container for it of some sort. We put it into a container because the radiation dose is usually higher if it's sealed. Since it's higher, how much can I stay safely from the patient? 6 feet, very good. And how long can I spend when I'm close to the patient?
Half an hour.
Or 30 minutes?
30 minutes.
For the
Okay,
day.
Day, right?
Yeah.
at a time, yeah, per day. So therefore, it's farther distance and shorter time because it's a higher dose. Make sense? So 6 feet, 30 minutes, right? This is for what? Sealed radiation. Let's go to unsealed. So unsealed radiation may be, remember thyroid, hyperthyroidism?
Yeah.
Okay. So an example of internal radiation is the one used to treat thyroid cancer or hyperthyroidism. So RAI 131, right? So the patient swallowed it, correct? They ingested the radiation. So therefore, can it enter body fluids?
Yeah.
Yes. Right. So the sealed radiation, because it was in a container, it was in a pouch, some applicator, can it enter body fluids? No, because they are sealed.
Sealed.
Unsealed, however, can enter because you swallowed it. So of course it will go into your GI tract, into the bloodstream, into any body
That's
system.
why you need separate foods.
Right.
separate-
So you have to take precautions with anything wet coming out of the patient. That includes saliva, urine, feces, reproductive secretions. Okay, sweat and tears are usually okay. Okay, there's really very minimal, if any, that comes out of it. Are we clear? All right. So because they're unsealed, so tendency is the dose the same as a sealed or lower? It's lower because it's absorbed by the body. Okay. So therefore, it's lower radiation. So how far can I safely stay from the patient? 3 feet. How long can I possibly spend with the patient? 1 hour. Okay. So shorter distance, longer time.
How about family members?
The same. Doesn't matter whether it's the nurse or the family, right? Right. Now, if you need to be all over the patient, you have to wear a lead apron. Because can you insert an IV from 3 feet away?
No.
Can you clean doo-doo from 3 feet away
No.
or 6 feet away? It's up to you.
Not everybody.
Be creative. Any question on radiation?
You tell me which.
Okay, let's go to complications or side effects. This will be the last. For what have you noticed with radiation therapy? Are the side effects
Not so
going to
severe.
be local or systemic?
Systemic, it's systemic.
I don't think.
Both, no?
Is it both? I think it's both.
Wait, can you repeat the question?
Okay, so because let's say we put it in the breast or with external radiation, we targeted it at a certain body part. So what's the side effect gonna be? Local or systemic?
Local.
Mostly local. Okay. The only exception, of course, is the internal radiation, which is unsealed. Okay. However, the one thing in common for these patients is fatigue. Fatigue is systemic, right? So that's the only very common side effect of radiation. Otherwise, it's mostly local. For instance, if I radiate the cervix or the uterus, I have radiation there. What will be my likely side effects? Can I have diarrhea,
Cramping.
constipation,
Yeah.
some bleeding, some bladder issues?
Yeah.
Yes, so it's in the around the region where it was where the radiation is, right? So mostly again local. Okay, so in and around the surrounding tissues. What if it's I got radiation in my lung? There's a tumor deep into my here, inner hilus of my lung, right here. It's tumor. That's the target of the radiation. What will be my side effects?
Shortness of breath.
Hard to.
Can I have pneumonia?
Yeah.
Pneumonitis? Could I also have pericarditis?
Yeah.
Yes, okay, my heart can also be affected. What about the skin? Because can radiation bypass my skin and then target only the lung?
No.
The tumor? No. So what will be a, right, so what would be a frequent skin effect? Dermatitis, okay? So there will be radiation dermatitis.
It says here that copper converters could also be one of those.
Correct. So it really depends on the region. So if I tell you on an exam and then ask you select all that apply, what will be the likely effects? And then I'll give you the region, or no, the organ, because you're supposed to know the region based on anatomy. So let's say I radiate, the patient received radiation to the larynx, and then I give you select all apply. What will be the complications?
Right.
Dysphagia,
Yeah, okay. That's what. Have to see.
hoarseness. Yes. Or let's say it's in the jaw. The tumor is in the jaw, and our patient received radiation to the head right here. Can the patient have dental caries?
Yeah.
Can the patient have xerostomia? Xerostomia is dry mouth.
I never know how to pronounce it.
So when I get my salivary glands radiated, what will happen? Dry mouth. Okay. When I put there bad breath.
Yeah.
Yes, dry mouth causes bad breath.
Yeah.
Yeah.
Um,
Right here. So xerostomia. So read the paragraphs. So it will give you examples. So here, head and neck radiation will cause stomatitis. What is stomatitis? These are large ulcers in your mouth. You've had canker sores, right? Okay. You've had canker sores? You know, you bite your cheek or your gum, your tongue, and it turns yellow, ulcer, very painful, right? Imagine canker sores the size of a quarter or a dollar coin and multiple ulcers. So even just a dime size, but you have 10 of them.
That's why people have to do them out, you know.
That's what stomatitis is. All right. So what would be consequences of stomatitis? Can your patient still eat?
No. Then have a pain.
Very uncomfortable. Okay. So they can forget about hunger. All they're concerned about is the pain in the mouth. Okay, we'll get to the interventions probably next week. We're out of time.
Okay, so can you just refresh me on what?
Up until here.
Up until here.
Okay.
So like,
Okay, let's finish. One of the effects, so let's say the radiation is internal, correct? So therefore there's some systemic absorption of the radiation. There will be GI, right? Because yeah, remember, cells absorb the radiation and then they die. Most cells affected are those that are rapidly dividing cells, which are going to be most affected by radiation and also chemotherapy. Describe the cell division rate of the cells lining your GI tract. When you get a chapped lip today and you put chapstick tonight, what happens in the morning? Is it still there?
Yeah.
It's gone. How come it's gone?
Absorb.
What is the cell division rate of your GI tract? Really fast. Does that happen anywhere else in your body? You get a chap here on your arm. Does it heal overnight?
No.
How come it heals overnight on your lips? That's how fast your GI tract cells reproduce and divide. Okay, so therefore, are they affected by radiation and chemo? Yes. So your symptoms would be anorexia, nausea, vomiting. And yeah, bone marrow suppression. Describe the cell division of your bone marrow. Is it slow or fast?
Bone marrow was
Slow.
Bone marrow cells, also fast, right? Yeah, so your red blood cell, platelet, and white blood cell production are constant, right? So you wonder how long do platelets live again? 7 to 10 days. So that's how fast they are replaced. Let's go to other sites that are rapidly dividing. What about your okay, we have it pretty much. Take note that the effects of radiation here are divided into acute and late effects of radiation. Right. So here we have systemic side effects, right? We talked about what about your hair? Your hair cells, are they also rapidly dividing? How much hair do you lose in the shower? Are you bald? How come?
Cause it's shedding.
They also grow fast, right? So therefore, are they affected by radiation and chemo as well? And then we have late effects, depending again on the site that was radiated or treated with radiation, will be the corresponding side effects, late side effects. All right, right. So therefore, your treatment will be toward, for bone marrow suppression, what will be your nursing care? Since the patient has anemia, neutropenia, and thrombocytopenia, what will be your care?
Bed rest.
Bleeding precautions, infection prevention, and how do you care for people with anemia? Besides blood transfusion, what else? Iron, how else?
And also there is a
What is your priority?
Poison alpha.
Yeah, poison alpha.
What is the number one symptom of anemia? Fatigue. So therefore, what's your nursing care for people who have fatigue?
Related to anemia.
Your nursing intervention, what will be your nursing intervention? Rest. Yeah, that's rest. Yeah. What about for the stomatitis? This one, stomatitis and mucositis are the same.
Poison swabs.
Can we use Listerine?
No.
What can we use? Alcohol? Okay, the doctor will order either saline mouthwash, or they will prescribe what's called a magic mouthwash. So magic mouthwash is composed of saline, and then they'll add benzocaine in it. You know benzocaine? It's a topical anesthetic. No, that's what's in oral gel. Yeah, oral gel. Yeah, they have antiseptics as well, but the magic mouthwash contains benzocaine. Okay, will contain an anesthetic. So when they swish it, it numbs, yeah, and then it will help make them comfortable with chewing.
With the stomatitis.
Yeah, yes, whatever, right. Right. Now it's swish and spit if it's only in the mouth. However, if the patient has sores, the stomatitis and mucositis is also in the throat, it will be swish and swallow. Okay. And sometimes, because are you at risk for fungal infections?
Yeah.
So it will also contain nystatin. So that's why we call it a magic mouthwash, because it has everything in it. So there's nystatin, there's benzocaine, there's either chlorhexidine or peroxide in it. Okay, so they'll do that 3 times a day before meals and also as needed. Okay, so a patient will either swish and spit or swish and swallow. Yeah, before meals and as needed. So that's your nursing management. What do we do with the hair?
You shave it off. Why you laughing?
Can they wear a wig?
Yeah.
Yeah.
Hey,
Do we protect the hairless scalp?
Yeah.
Okay. So the distance is here. Okay, I mentioned the 6 foot distance and 30 minutes. And somewhere there will be the 3 feet and 1 hour as well, or 60 minutes.
and that's in the nursing management category, right?
Right. Okay, we'll continue with chemo next week.
Is there, wait,